Hey everybody, today I'm going to try out a new format for the articles. A couple of people have mentioned that they really like being able to read them. They can sit down on their lunch breaks or whatever. But a few other people have mentioned that they like the video because they can play it in the background while they're working on something else. And obviously I feel like this is all important information, otherwise my awkward self would not be on camera. So I want to make it as easy to digest as possible. So today I'm going to try to, I'm going to kind of split it up. So the video portion will be just sort of the meat and potatoes. What condition are we talking about? Symptoms, causes, treatment, etc. And then the narrative below will be any personal or professional experience that I've had with this particular condition. So let me know what you guys think of the new format. If you like it, if you hate it, if you think I should do it a little differently, I am open to suggestions. That chair squeaking is going to drive me crazy. Okay, so let's just try to dive right in and see how it goes. So today I'm going to talk about something called post-op psychosis. It has a few other names that it's pretty commonly known by. There's ICU delirium, ICU dementia. Those are all pretty common. Unfortunately, like a lot of disorders that aren't well researched, there's not one particular name. It's more of like an observed phenomena at this point than a diagnosable issue because there's not a lot of... Anyway, I'll get off that little soapbox and we'll discuss that later. So, sorry, I'm gonna grab my notes here. So, what is ICU psychosis? By definition, it's basically when a patient who is in the intensive care unit or post-op psychosis, they've gone through a major operation or surgery, starts to exhibit sort of this nasty cluster of psychological symptoms that isn't normally explained by any of the medications that they're on or the treatment that they're going through, etc., blah, blah, blah. So what exactly do I mean by a cluster of psychiatric symptoms? Because that's really vague. It can include a bunch of different things from paranoia, delusions, hallucinations, anxiety. Let's see, what else have I written down here? Nightmares is a big one, agitation, all kinds of abnormal behavior. Those are all very common symptoms of ICU psychosis. Obviously, those are very alarming. And unfortunately, with ICU psychosis, it's usually a very rapid onset. It happens very fast. It comes up very quickly. It's not expected. It can last anywhere from a few days to a few weeks. Usually it clears up shortly after the patient has gotten out of the ICU, but sometimes it can last much longer, which is why I think it's pretty important to pay attention and to research this condition. I'm going to say that probably 100 times during this video. Okay, so what can cause ICU psychosis? Because I'm going beyond the normal spectrum of the confusion that comes with opioid pain medication or being a little bit out of it after anesthesia. I'm talking about way past that. I'm talking about when all of a sudden a patient thinks that they have been abducted and they're being held against their will and the nurses are poisoning them and they are 110% sure that this is factual. I mean, it resembled so closely some of the schizophrenic patients that I have worked with that it was alarming and it set on very quickly. And I'm very frustrated by my recent experience, which is what elicited this post, but I'm going to try to not get too off topic. Gosh, that chair is driving me crazy. Okay. So what can cause ICU psychosis? I'm pretty sure I already said that. There are a lot of factors that come into play. Sleep deprivation is a big one. Medications, treatment that you get after ICU care or during ICU care is more accurate. All of which is necessary. So I'm not at all trying to say that those things should be stopped. Clearly, if you have open heart surgery, there's going to be some pain medication involved after. But that can be a factor in whether or not a patient gets post-op psychosis. It's much more common in the elderly. Anytime that an infection sets in after a big operation, that can increase the odds of getting post-op psychosis. Dehydration is a big one. Metabolic imbalances like oxygen levels or blood sugar, all kinds of things can contribute to the odds of getting post-op psychosis. That being said, there are a lot of other conditions that produce very similar symptoms. A stroke, for example, can also produce a lot of those psychiatric symptoms, which is why I think when a patient starts to exhibit those symptoms, it's very, very important to rule out other possible causes, because if your patient has had a stroke and you're assuming that it's ICU psychosis, you could very potentially be causing some other major issues and life-threatening issues. Even if it doesn't end up being something that serious, even if the odds of it being something that serious are very low, I think it's owed to the patient that at least be ruled out once ICU psychosis has set in. And that's the only way to diagnose it, is to rule out all other possible causes. So, let's say that you have gone ahead and done that. You've identified that the patient is having this abnormal behavior. You've ruled out other neurological causes, biological causes, etc., which unfortunately rarely happens, for the record. I've spoken to quite a few nurses and doctors at this point who, after I described the situation and experience, they said that they were not at all surprised that it's quite common. And statistically, the research that I have found shows the same thing, that anywhere from 30 to 80% of ICU patients get ICU psychosis. And yes, that is a horrible range of statistics, but I got to work with what I got. So the problem there is that doctors expect it, but they don't tell families or patients to expect it. And then when it happens, because the doctors expect it, they don't necessarily take the time to address it. And that's a huge problem, because A, if it's not ICU psychosis, if it's actually side effects of something like a blood clot or a stroke, you're ignoring that. B, when the patient's upset and the family is upset and they're all confused, nobody knows what's going on, the patient isn't going to recover as well, making risk of things like infection or cooperation during treatment it's just worse. It's generally worse for everyone involved, and the whole point of being in the ICU is to get that person stable. I understand that medically there are things that need to come first, but I don't think that ignoring ICU psychosis symptoms is acceptable behavior. Clearly, I'm a little bit upset about this topic at the moment because I've gone way off on a little soapbox again. I apologize. I'm going to try to reroute here. Get back on track somewhat. Okay, so the only way to diagnose ICU psychosis is to rule out the other things that can cause similar symptoms. And I know that that takes a lot of time. If you think that they might have a blood clot, you have to, set up a scan, get the patient down there. They're hooked up to all these wires and tubes and crap already. I get it. It's kind of a pain, and you're busy, and there's tons of other patients in the ICU. But until you can clarify that it's actually ICU psychosis and not something else, you can't start to apply the appropriate treatment. So, let's say everything else has been ruled out. Pretty sure that's where I jumped off track earlier. There are a lot of conditions, like environmental conditions, that can contribute to the length and severity and the likelihood of getting ICU psychosis for a patient. So if you can determine that that is actually what's going on, you can look at those risk factors. For example, sleep deprivation is a huge risk factor. Having a secondary kind of infection, in addition to the fact that your body is already trying to adjust to whatever trauma has you in the ICU. When patients feel like they're not in control. So an elderly patient doesn't have their hearing aids anymore, or hasn't been allowed to have their dentures in the ER with them, in the ICU with them. They aren't getting to choose what they're eating or when their meal times are, when they're going to the bathroom, when they're being bathed. That loss of self-control can be really hard. And it makes ICU psychosis more likely to happen because they're already going through a lot of other things physically and their brain is struggling to keep up with that. Sensory deprivation is a big one. So if you're in a dark ICU room, shades are pulled, you don't get to see outside, it's quiet other than the beeping of machines that's keeping you up all night, people aren't coming to see you. I mean, that's a huge shift from a normal day-to-day activity where you interact with all of these things around you, and now you're just bedridden and there's nothing coming in. The brain doesn't adjust to that very well, and that also increases the odds of ICU psychosis. So once that happens, if you can start to address some of those things, for example, if you can say, this person has ICU psychosis, but we also know that they haven't slept in 4 days and that they're having a hard time keeping themselves hydrated. Give them an IV, give them something to help them sleep. I can almost promise you that that will help with their symptoms. And I know that's not always as easy to be done as it is to be said, but if you want your patient to recover, I think it's important to address mental health with the physical health because they do impact each other quite a bit. On top of that, it is important because I actually found during some of my research, and this is really upsetting to me, when ICU psychosis is not properly diagnosed, it can lead to a lot of other very avoidable things down the road that make life for a patient really difficult. PTSD can set in for long periods of time after they're out of the hospital, after they've recovered from the medical condition itself. I actually read an account about somebody who had been incorrectly diagnosed with dementia and sent to a nursing home, even though they were suffering from ICU psychosis, which is something different and something that can be recovered from. It can also mimic other dementia symptoms for long periods of time after they've left, like short-term memory and all kinds of cognitive functioning that if it would have been addressed in the hospital, possibly could have been lessened, if not completely avoided. So while I understand that behavioral stuff in an ICU is usually not priority, because obviously life-saving medical stuff needs to come first, I don't think that not having some kind of plan in place for treatment or prevention or even just for education is acceptable. I think those things have to be implemented. And right now, it's across the country, this is a huge problem. There is a doctor out of the Vanderbilt University Medical Center who has started paying more attention to this particular condition, and he's developing something called the ABCDEF protocol to help monitor for ICU psychosis and address how to treat it and avoid it if possible. And I'm very disappointed to say that he has not gotten a lot of traction in the medical community to actually work on this with him, even though his results have been fantastic. I actually found a video of him talking about how he got involved in this process, and I'll make sure I include it at the bottom here with my sources. But for it to be ignored as much as it has been and currently still is being ignored when it's something that's so easily addressed is something I don't find acceptable. I'm a little bit fired up about it right now, actually. I'm having a hard time staying on track because I'm really irritated. um, I apologize. Clearly, I have my sassy pants on today. Okay. So, what do I think should be different? Why? What do I think needs to change? So, if you're talking with a family or a patient who's about to have a major operation, I think you need to explain to them the possibility that ICU psychosis may happen. Tell them what it looks like. Tell them what to watch out for. Let them know what the odds of getting it are, because I can tell you that if a patient suddenly starts having a lot of delusions and their family has no idea that they should have been expecting it, it's going to go much worse, not just for the patient and for the family, but also for the medical staff that have to interact with them, than it would have if, say, the family said, oh, actually, the doctor said this might happen. Okay, let's let them know what's going on. This isn't a surprise. When you can avoid shock, it's always a good thing in a medical situation. I think most of my rage, I don't know if that's quite the right word, disappointment maybe, came out in the dialogue below. So if you're looking for more of the story picture or a visual of what ICU psychosis looks like in a patient, that would be the place to read that. I had intended on only covering the basics in this video, so I'm hoping that I did that and that at least you are aware of what ICU psychosis is, what could potentially cause it. So, like I said, if you can avoid those things in post-op recovery and in the ICU, if you can keep them on a normal sleep schedule if and when possible, if you can make sure they have things like their hearing aids and visitors and stuff from home that makes them feel like they're not in this completely foreign environment, you can make sure they're staying hydrated, things like that, you can avoid and lessen ICU psychosis symptoms. That being said, obviously, I don't even know where I was going with that. I apologize. I'm a little bit emotional about this topic right now, so I maybe should not have videotaped this today, but I feel like everybody needs to be aware that this is a possibility, because when the odds are anywhere between 30 and 80% that a patient will have this condition and that they and or their families are unaware of it, and worse, when they bring it up to a medical professional and it's not addressed, I find that unacceptable. I mean, 25% of the people who have ICU psychosis end up with PTSD afterward, and I think a lot of that could be avoided as well. They go into the ICU with a medical problem and they come out with a psychological one, and I'm not sure that that should be the goal. I mean, why is the goal not overall wellness? Okay, I'm gonna stop here because I'm getting myself worked up, and the more irritated I get, the more off topic I get. So hopefully I covered the basics. If I didn't, please ask questions, let me know, and I will reshoot the video if necessary at a later date when I'm a little less angry about this particular subject. In the meantime, I encourage you to read the dialogue below. It outlines a recent experience I had sitting with someone while they were experiencing ICU psychosis and their family, and the reaction I got from medical staff, which will give you a better picture of what it looks like, but also what families and patients are up against when they're suffering from this. So if you take anything away from this video, it will hopefully be that almost always my articles are fueled by some sort of anger or frustration or lack of sympathy about a subject that usually you don't pick up on in my writing, or maybe you do, I don't know. But like I said, I hope this was an easier format for some of you to grasp the concept. I realize I rambled a lot, and I will try to have them better outlined and structured in the future. But please, 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 please be aware of what ICU psychosis is. Be aware of the possibility. If you know someone who's about to have a huge operation, like open heart surgery, make them at least aware of this condition so that if it happens, they are a lot less terrified. Because I think people deserve that kind of education and that knowledge, because the best thing to fight fear with is knowledge. And if you can be aware of what's going on with your body and with your brain, it's going to freak you out a lot less. And if you're less freaked out, you're probably going to get better faster, which is sort of the goal of the ICU, unless I am misunderstanding. Sorry, getting upset again. Okay. I'm going to jump off here before I go on another little soapbox rant. Ugh. Like I said, let me know if this is a format that you guys want, if you like, if this is better or worse, whatever, because I realize I'm rambling a lot, and I promise I will work on that in the future. So I'm going to end the video here, which I also don't know how to do because I'm from the Midwest, and people in the Midwest don't really say bye. They just sort of stand by the door and awkwardly talk for 45 minutes while one of them tries to sneak out. Yeah, okay, I'm just going to cut the video off. Have a great day. Please give me your feedback. Thank you for watching if you've made it this far, and sorry you had to put up with blah, 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 that.